for a couple of moments. Yeah.
Just wait for a few minutes for everyone to join in, then we can start. In the interim, we have some announcements for the participants. So, a very good evening to all the esteemed panelists and the participants to this community of practice session on Canadian Neonatal Network, Key Learnings and Potential for Adaptation in South Asian Region by Dr. Prakesh Shah, sir. I would request Dr. Vikram Datta, sir, President NQCM, to introduce Dr. Prakesh Shah, sir.
Thank you so much, Dr. Ashna. Good morning, good afternoon, and good evening to our international participants and participants from South Asia to this Communities of Practice session of the NQCN Communities of Practice for Point of Care Quality Improvement. Friends, I welcome you to this second session of September 2021, in which we have a very exciting presentation today, and I'm sure it will be very enriching for all of us to learn from the Canadian Neonatal Network. And we have none other than the driving force behind the Canadian Neonatal Network. And I welcome Professor Prakesh Shah. Professor Shah is the Pediatrician-in-Chief at Mount Sinai Hospital, Toronto. Professor Shah is working at the Department of Pediatrics and Institute of Health Policy Management and Evaluation at University of Toronto, Canada. He currently leads the National Evidence-Based Practices to Improve Quality, that is the EPIC initiative, about which he will be talking in greater detail in his presentation today, which engages actively 31 tertiary NICUs in Canada. Professor Shah is also the director of the Canadian Neonatal Network, Canadian Preterm Birth Network, and an international network for evaluation of outcomes of neonates. That's INEO. He oversees a project of benchmarking outcomes of very preterm neonates in 11 countries besides Canada, with population-level neonatal networks with an overarching aim of improving quality of care across 240 networked global neonatal ICUs. Well, this is something I'm sure the NQCN communities of practice neonatal experts and our nursing colleagues would be very interested to learn, with NQCN embarking on a mission to start collaboratives right across the South Asian region, with India making a maiden journey into the launch of neonatal collaboratives. Professor Shah is also co-PI evaluating preconceptional, prenatal, and postpartum interventions to develop healthy trajectories of growth in a cluster randomized trial in southern India, and has been regularly contributing to academic sessions. And I was privy to one of his very excellent sessions which he held with the Kerala NNF, and I happened to be one of the panelists in one of the sessions with him a few months ago. And that is when we got introduced to each other, and this is what has led to this session. His areas of interest are patient and disease-oriented research in neonatal perinatal medicine, health services, and epidemiological research in maternal newborn care, knowledge synthesis, and quality improvement. So friends, without much ado, I have the honor of calling upon Professor Prakesh Shah, who's going to be talking about the key learnings and the implications for adaptation in Southeast Asian region of the Canadian neonatal network. So over to you, sir. The screen is all yours, and we look forward to an exciting presentation from your side. Thank you so much.
Thank you. Thank you very much. First of all, I'm privileged and honored to be here, and thank you for that kind introduction, and thank you the panelists, and thank you for giving me the opportunity to share some of our learnings with you. I just have a disclosure to make in that I have nothing to declare except for the fact that I am so much indebted to what I have learned and where I am from where I started, which was in Ahmedabad. I did my undergrad and postgraduate training in Ahmedabad, and then moved to UK and then to Canada. So I owe everything that I have learned to my start back home. And Dr. Vani, though we were not directly involved in training me, but we have been always looking towards her achievements when we were residency when at that stage as well. So I'm so much honored to be here with her in this session. When Dr. Datta asked me to talk about our experience, what I thought was that let me go back to basics as to what is quality improvement, what is quality assurance, what are these quality terminologies, and what are the quality methodologies, because that may be of interest to the audience here, and then take you briefly to our experience, which in itself could be a long talk as well. But at the end, I would like to conclude as to what have we learned, what are the challenges, what are the barriers, what are the facilitators, and how it can be initiated. And some of it is already work in progress in Southeast Asian region, and how it can be enhanced. So just to go back to a little bit of history as far as quality improvement is concerned, I mean, it's not a new thing. This is not something that was invented yesterday or 10 years ago or 15 years ago. This has been a cornerstone of activities for our lives, knowingly or unknowingly, starting from Walter Stewart in 1891 to Paul Batalden and Don Berwick, who have been leading this flame in the US currently as well. So it will be unfair to start these sessions without these giants, acknowledging these giants and presenting you with a bit of history. And between my slides, you might see what you see at the bottom, a little bit of snippets from these giants, which will enhance and enrich the message that I might want to pass it on to you, that you may be able to read in between. I would not be going and reading those messages, but one of the key messages that every system is perfectly designed to achieve the result it gets. And unless you transform the system, it will not improve the results. You will be satisfied. So please keep an eye on those snippets that you will see. So what is quality improvement? It's basically a systematic data-guided activity, which is designed to bring about immediate improvements in healthcare delivery in particular settings. Now, this is the original definition as far as healthcare was concerned. However, it has been transferred into a number of different iterations. But essence of it is that it is a deliberate and defined improvement process, which is focused on activities that are responsive to local needs and improve health. Another way of looking at it is it's a continuous and ongoing effort to achieve measurable improvement in any of the domains, such as efficiency, effectiveness, performance, accountability, equity, and outcomes. And keeping this in the back of your mind, you would see that there has been a number of attempts, a number of suggestions, a number of guidance documents that one can go and follow if they want to initiate a quality improvement project in their own setting. And I am not here to teach you what and how. I'm just going to give you the flavor of different aspects and what we adopted out of those and what results we got. However, you're more than welcome to choose any of this. These are all perfect and can give you improvement that you will be looking for. However, before one starts or thinks about quality improvement, we need to understand few terminology. What is quality assurance? What is quality control? And what is quality improvement? And in a simple terms, I would say that if you are a system administrator, you are a regional administrator, you're a health minister, what you will be looking for is that I have 100 hospitals in my area. There are some which are very good performing, which is on the left side of this bell curve, and some which are not performing better, which is on the right side of this curve. And this, if you set yourself a threshold that below this, it is not acceptable for any institute or any outcome to happen, then what one would do is just cut off, close these hospitals, tell them you can't work, you can't function because you're not performing well. And what that will lead to, it will lead to move your mean to the left side. However, the people living in that particular area will suffer because they will not have access to reach to that particular care that you are intending to provide. And that is quality assurance. You're just making sure that everybody has to perform, and those who are not performing, you cut them off. This you can do if you have 100 factories producing cars for Toyota, and you can say these 5 units are having a lot of defective units, close those units. We can't do that in healthcare because we can't close those institutes or hospitals because we need them to provide services. So coming to next step, which is the quality assurance. Quality assurance is a process, procedure, standardize, and you audit. Meaning thereby you make sure that whatever you are intending to deliver is being delivered. Okay. Or just giving you a simple example from the neonatal world kind of thing. You want to build an NICU, you want to put hand washing sinks for every 4 beds. There is a one sink that people can go and wash their hands. So that's quality assurance. You are making sure that this is a quality metric that I want to follow, and I'm going to put one sink across 4 beds, 10 beds, whatever you decide. Quality control is to make sure that those things work, that they have a cold water, they have a hot water, they have a soap dispenser, and they function all the time. That is quality control. If temperature is not good, call the engineers, fix the temperature, water comes. Soap is not coming, add the soap. So you identify issue and meet your quality assurance goals, that there is the sink which is functioning. Whereas quality improvement is making people use those sinks. Because no matter you put 10 sinks in your unit, and if people are not using it, it's not going to be useful and it's not going to give you the results you are intending. So what quality improvement looks for in the previous chart that I showed you is that bell curve. There are poor performing units, but what you try to do is to improve everybody, bring them back to the normal curve or make it better. So 2 things you do in quality improvement. You make everybody better. You not want to penalize these people by bringing everybody over good unit on the right side. Make everybody better and make the variability less, because this is a huge variability between the outcomes. And the one goal is to reduce the variability and make it better. And that should be the goal of quality improvement. And that is quality improvement as compared to other quality matrices that I showed you. And in this talk, I'll try to explain how this functions and how this can be achieved. The next question is, why should I worry about, why should I do quality improvement? What is the importance? Now, quality improvement is innovation. And until that bulb lights in the system, in the administrators, in the people, it is always looking like an extra work. Because what you're doing in quality improvement is you're systematically approaching to achieve higher incremental performance. You go out, you look for, and you seek the best in the best class and try to mimic them to achieve their outcomes in your particular setting. And in doing so, you may have to innovate yourself, because the one item or one process that worked in one unit or one place would not work in another place in the similar fashion. So you may have to innovate, you may have to cultivate your own process and get the results that you are going to be striving for. Why should we focus on quality? First of all, quality improvement has no limit to what is better. If you have achieved something, tomorrow you will be trying to achieve more. Second and most important thing is that there is no new money or no new support. So quality improvements helps you to deliver the intervention within the resources that you have and how to restructure, how to organize it better to improve outcome. So that's one of the focus. I mean, of course, if you have money, you can always do better, but most of the systems are striving and struggling to find extra money. So you have to work with the existing system of care to improve the quality. And that makes it a little challenging, but exciting. And the other part is why we should be doing quality is what you see here on this slide. And the x-axis is time and the y-axis is progress. Science is progressing at a rapid rate. Is patient care progressing at the same rate? Probably not. And we are seeing increasingly higher amount of quality gap between the science and patient care. And the only way to do this and reduce this gap is to have a continuous quality improvement program so that you try to bridge this gap and not run far behind. And what has happened over the last 20 years in the neonatal intensive care is, for those who are not neonatologists, is that there isn't a special molecule, special treatment, or special ventilator that we have seen that has arisen or come to our fruition. What has happened happened in the past. We had ventilation, we had antenatal steroid, we had surfactant, and we had nitric oxide and ECMO. Since 2000, there is nothing that has come which has revolutionized a molecular biology that is going to make babies better. And despite that, everybody has improved survival. Everybody has improved outcomes. How? Being gentler to the baby, avoiding things that we used to do before, including family, and do it what we know better and do it what we know consistently. And those are the pillars of quality improvement. We have done randomized studies. There is nothing to take out from the randomized studies, but in the last 2 decades, that it's a quality improvement, understanding, learning, and applying that has made the changes in the neonatal world. So with that background, I'm going to tell you about a humble experience that we have in the Canadian Neonatal Network for last 25 years. Canadian Neonatal Network is a network of tertiary neonatal intensive care units in Canada. So we have 31 neonatal intensive care units in Canada, and all 31 are members of the Canadian Neonatal Network, meaning thereby every baby, we know what is happening in the country and learn from each baby. And are we saying? No, we have very, very different size unit, different capacity unit, and different capability units. We have unit which has less than 100 babies admitted every year, and we have units which has more than 1,200 babies admitted per year. However, in a regionalized system, Again, if I put it, they will come out as a bell curve, and I cannot take out five sides not performing well, because that will make suffering to the people being served by those communities. And it all started with our first iteration of collecting data in 1997, 98, where we found that the mortality varied from 1% to 14%. So this is the mortality for preterm babies less than 32 weeks. And it varied from 1 to 15%, 14% in different units. And the question came, why? There was a public outcry. People wanted to know who is site M and who is site N, because they don't want to go to A and N and H, but they want to go to M, J, and D, which is not what's the purpose of this for. Purpose was to identify opportunities to learn. And then in 2005, there was a Japanese fellow that came to Canada to do his fellowship in neonatology. And when he came after 6 months, he told me that there are vast differences in how they manage babies in Japan compared to Canada. And he would like to compare the outcomes. He says, no, you might have heard Japan has a better outcome stuff. And I said, well, bring the data, we compare and we learn from each other and we see what happens. So this is the blue is Japan, red is Canada. And this is mortality or any major morbidity by gestational ages. And as you can see, in Canada, the mortality or major morbidity was significantly higher for babies less than 26 weeks. However, when you go to 27 to 32 weeks, Canada was doing far better than Japan. And that opened their eyes as well as our eyes. We thought, oh, we are not doing good for the small babies, but they learned that they are not doing good for the little bit more mature babies. And that triggered why, what. And then we went into the detail as to what is the reason, what are the outcomes are better, where, and how. And that started the process of learning between the countries as to how can we learn and what are you doing that makes your outcome better, and what are we doing that makes our outcome worse. For non-neonatologists in the audience, the first left panel is bronchopulmonary dysplasia, which is the chronic lung disease of premature babies. And the right top panel is necrotizing enterocolitis. And you will see the stark difference. So the bronchopulmonary dysplasia is worse in Japan for each gestational age. Necrotizing enterocolitis is worse in Canada for each gestational age. And then a team went from Canada to Japan to see what they are doing. And a team from Japan came to Canada to see what are you doing. And we learned different ways of approaching how they were doing the lung management and how we were doing the gut management, to learn that, okay, what needs to be done so that both outcomes improve in both countries. And that's where I established what I call the International Network for Evaluating Outcome. I'm showing you the half of the panel. I'll show you the rest of the panel later. But you can see the composite outcome of mortality and major morbidity varied from 68% to 42%. So there are countries with a lot better outcome, and there is country with a worse outcome. Now the red one is Canada. And that's where we say, well, we can't be the worst in the 11 countries that we are comparing, which are the high income countries. And I will tell you what we did. So that's where we conceptualize the network aspect to improve outcome. Our idea was to build social capital, encourage and foster collective values, and design the system for a continuous evolution. So we took off this paradigm. We already had data. We were converting it to information, but we needed to go to the next phase, because creating annual report, sending people report doesn't do much. We needed to convert that information into community collaboration, in advancing knowledge and getting wiser. I wouldn't say we are completely wise yet, but getting wiser and wiser day by day. And I will walk you through that process. But before we started, we had a question like, what should we do? How do we improve quality? There are several methodologies that one can adopt to improve quality, to improve quality. There is clinical audit, there is a lean method, there is Six Sigma method, total quality management, performance benchmarking. Now, in small snippets, I will tell you about each. So clinical audit is basically you check whether your clinical care meets defined quality standards, monitor improvement, such as hand audits, hand washing. And I'm sure many of you are doing this. Lean principles are based on a problem of waste reduction in duplicate work, and redundancies. So it deals with the flow and process issue. And if you adopt that principle, it will help you to improve the flow and simplify your process. Six Sigma is geared towards reducing variation and understanding complex interaction between the systems. So it uses data and provides robust, sustained control measure. Total quality management by IHI, again, deals with the flow issue, localized problem, and where you have no or less resources. So that's why total quality management method is useful, because you develop aim, develop cycles, and then do multiple situations. And finally, performance benchmarking, which is looking at what is a performance issue. You compare your inefficiency. Initially, you don't have data, and then you start to flow the data with continuous information, develop or key performance indicators, and do the visual displays and ask people to work on or look at it and improve the outcomes. Because as you can see at the bottom, Edward Deming said, without data, you are another person with an opinion. In all these processes, there are a lot of useful tools that people use for quality improvement, such as driver diagram, process mapping, fishbone diagram, affinity diagram, Pareto chart, Pdsa cycle, root cause analysis. All this is how you want to measure what you're doing or what you are planning to do, and how you want to measure what outcomes you achieve. We can go into details of each one in the question answer if anybody is interested, but these are the ones that you can look it up. You don't have to do all. You just choose one and then follow that particular. So I will tell you our experience, what we called evidence-based practice for improving quality, Canadian Neonatal Network. And our base principle was to promote dialogue by creating teams at each unit, share and evaluate each other's data, share and evaluate each other's best practices or intervention, and then see what happened and what do they learn and how one other side can implement those things. In this process, we train teams in each of these units by adopting different principles of what I told you and creating a curriculum in a simple 10 steps. So I'll walk you through those 10 steps, because this may be a very simple, very trainable, and very adoptable technique for a resource limited or resource rich setting, because it doesn't require rocket science. First step is to identify problem. Let's say we have babies who are cold. Like why? What is the problem? Why can't and why? So your first step is identifying problem. I'm not going to go into details of each step. Second is you select your team who is going to tackle with this problem. Optimally 4 to 6 people or 8 people maximum. Identify champions. Make sure these 6 people are not your unit directors always. You need to be including people who are going to really work on that particular problem. Different professions. Make sure there is one administrator that is included in that. And then have that team brainstorm causes. Causes are divided into 4 P's. It's either people, places, policies, or procedures. So on the right side of this fishbone diagram, you have problem. And then you try to find, okay, where is the problem? Is operating room too cold? Is where mothers are delivering the babies too cold? Are the babies not being put to mum for skin to skin care immediately after birth? Is that the reason? Or is there no blankets available, or no hats available, or no training available? So you just brainstorm the causes as to what is the reason. You will find multiple causes, and then you have to prioritize. So you use some kind of tool to prioritize, okay, what is the low hanging fruit that we want to tackle first? So what is a priority that is in your control, that is impactful, manageable, affordable, and measurable? And give the score, and then take one by one. That doesn't mean that you take only one and stop. You use them to do one by one. And then map out the process. Okay, mother comes, what happens to the baby? Just map it out in such a way that there are decision points and there are process points. So the yellow are baby is born, baby goes to mother, need to help to the breath, then yes, no. So those are decision points. So map out the whole process. We have teams who will create the whole wall filled with this stickies. And then you identify what you want to measure. So there are always two types of things you can measure. One is called, it's balancing indicators. So one is what you want to achieve, but second, what adverse outcome you might end up. You might end up having babies with hyperthermia by doing overzealously what you wanted to do. So you have to have a balancing indicator with whatever intervention you're trying to achieve. Step 7, explain this. So put this whole thing in paper so that everybody involved in the care of the baby knows what we are trying, what is our aim, what is our process, what is our outcome, and what is balancing indicator, and why this change is important. It's important to explain to everybody. And then engage the partners. It could be parents, it could be staff, it could be your administrator, and see where is the problem. Are they not aware of it? Are they not thinking? Are they not planning? Are they not acting? Or are they not maintaining? And then work out a process as to, okay, who needs to be engaged in achieving the goal that you want to achieve. And then implement this. So this implementation is called Pdsa Cycles. Plan, do, study, and act. So you continue this cycle. So this is one intervention, second intervention, third intervention, and the fourth. So you study them continuously, introduce them on a regular schedule, whatever works for your particular unit. And then come and tell everybody. So do this group work and present to others so that others learn. Or you can tell that, look, we tried this and it didn't work, and why it didn't work. You can do that brainstorming so that the whole system knows how the process is going, and share this knowledge by showing that, look, this is the incidence of hypothermia after introducing skin to scare staff training, number of babies being cold by monthly. And you can show this and then continue to advance. So the next intervention will take it from the right side to even lower rate. Having said all the theory, practically, we started this journey in 2002. So it's now nearly 20 years of experience. We did it in the modules of EPIC 1, which is second one was partnership in health system improvement, then EPIC 2, 3, and currently running EPIC 4. And the conceptual model is you need to have your input, which is your data and what works from the reviews in the literature. Then you process, analyze your data continuously and plan, implement the process of cycle, audit, and go back to the data and then run this cycle again and again. Giving you an example, this is a unit where a baby is born. There were 14 steps before the baby will receive surfactant, because they have to have initial step, then an X-ray, then this before baby gets surfactant. That means it was taking 2 hours before baby receives surfactant in that unit. And they felt that that is not correct. They identified the barriers to change. The surfactant was from different program, different budget, not kept where the baby was born. There were old criteria, all those problems that they identified. And they worked out the solution, set up a working group, identify and tackle obstacles. And then next time, then when they came and presented, it was 3 steps with a target to get the baby surfactant within 30 minutes. And that's what they aim to achieve. And they achieved like this. So this is their median age at receipt of surfactant. And you can see the steady reduction. Still, they didn't reach the 30 minutes, but you can see they came down from 300 minutes down to 100 minutes and working towards going to the 30 minutes. I can give you multiple examples of such intervention. We did not limit them. We just said, you find your solution and work with your solution. We didn't force from center saying that everybody has to wash hands or everybody has to do hand hygiene audit. So you identify your problem, deal with your problem, and tell us what you did. So you can imagine in the initial days, this was not a well-known phenomena, quality improvement. So we had to do a cluster randomized trial where we randomized 6 units to reduce infection, nosocomial infection, and 6 units to reduce bronchopulmonary dysplasia, which is the chronic lung disease of prematurity. There were 5 NICUs which said, we don't have resources, we can't. We said, you just stay as a control. We're not going to do anything in your unit, and let's see what happens. And lo and behold, the infection went down in the infection group by 1/3. Simultaneously, when your infection is low, your chronic lung disease will go down. In the chronic lung disease group, the chronic lung disease went down, nothing happened to infection. Importantly, in the control group, there was no change. The rate remains same. So we concluded that it is effective in reducing infection and BPD. If you target one outcome, you may have a better outcome, better outcome. And this may be a more effective and less costly way than doing one intervention randomized controlled trial to improve outcomes. So we were happy, and everybody was thought that, oh, Canada is on a good track. We don't have to do anything. We closed our hands. Other units which did not participate came to us and told us that, okay, tell us what you did. So we gave everybody's intervention to them on a paper without immersive engagement of team, without training the team. And what happened? The units which had the training continued to improve. The units which got the paper saying that, oh, these are the intervention to reduce infection, over the next 3 years, nothing happened to those units. They just basically rate remained same. And that taught us that just disseminating information doesn't help. You have to reinforce the key concept of how to do quality improvement. Just telling unit what we did without the process is not effective. And that's where we said, well, we can't leave like that. We need to do more. So then we started EPIC 2, which is 2008 to 13, engaging all NICUs and targeting high-risk babies, which are less than 29 weeks, and now targeting more, which is morbidities and mortality, and to measure their neurodevelopmental outcome over 5 years. A lot more work was done, a lot of reviews, identifying the indicators for each one, teleconferences, workshop, annual workshop. What we found in 3 years, that the odds of adverse outcome reduced by 37%. The adjusted odds was 0.63. What also we learned that most of the improvement occurred in 26 to 28 weeks babies, but not in 22 to 25 weeks. So tiny preterm babies, there was not much improvement, but a little bit bigger, 26 to 29, that's where majority of improvement occurred. So we learned that there is still room to improve. And when we looked at individual morbidity, we also found that bronchopulmonary dysplasia and brain injury did not improve much. They basically practically remained same. Most of the improvement occurred in ROP, eye disease, gut involvement, necrotizing enterocolitis, and infection. So we learned it is effective, but we also learned it is effective in improving other outcomes, but still more work to do. But importantly, we found out that now this process is generalizable. Initially, it was scientific by randomized controlled trial. Now it is generalizable. And that's where we didn't want to give up and stop. We continued on this success to sustain this effort. So launched the EPIC 3 immediately and continued this activity with some addition of unit visiting other units and learning from there. And again, continued to show a reduction in composite outcome over the next 5 years as well in the same group. So meaning thereby this process remains sustainable. But still more work to do. However, in those 5 years, what we found that every 60 to 70 babies that we treated, we had 2 less deaths, 3 less necrotizing enterocolitis, 4 less infection, and 8 more babies went home without any morbidity in 2030. And that was a big, big achievement. I don't think any randomized control trial has achieved this. So summarizing, in EPIC 1, we found it is scientific. In EPIC system improvement process, we learned that what works and what does not. Then it was generalizable. It is sustainable. And now, currently, we are running the process of advancing it with a comparative effectiveness studies. We are targeting some important interventions that we all struggle, and half of the unit do one way and half of the unit do other way. So I hope I've convinced you that we have developed community, collaborated, developed knowledge, and getting wiser. However, this is all in an epoch. We need to see, is this really had made improvement over the time? And as you can see, at individual gestational ages, so starting at the bottom from 23 to 25 weeks to the 31 to 32 weeks, there is a gradual and steady improvement in outcomes from 2002 to 2017 in Canada. This is entire Canada. And that corresponds with the individual morbidity going down over that time as well. And you can see this in the last column, the composite outcome has reduced by 20% from 2003 to 2017, meaning thereby 20% more babies are going home without any morbidity. We also learned that we need to go to the other side of the cord. We did everything on the right side of the cord, but we need to go back, because if babies are born in a better condition, then we will get a better outcome. So we partner with our obstetricians and maternal fetal medicine specialists to work on projects like deferred cord clamping, judicious use of antenatal steroid, judicious use of antibiotics, use of magnesium sulfate, enhancing the use of magnesium sulfate prior to babies are born. So this process is going on now, and that is also showing increasingly improvement. Again, one could say that this may have happened by just chance because everybody in the world was improving. And if you remember, I showed you the graph, which was broken at the start. We were the worst in those 11 high-income countries. We are now second best in 2015. And look at the other countries. They're either static or they have worsened as far as the outcome of the small babies are concerned. So it is not that just happened because of the time. It happened because of the continuous and immersive engagement. And in that process, what you're seeing, the first graph that I showed you. So on the on the x-axis is the rate of composite outcome in different unit at a unit level in the country. So this is Australia, this is Israel, Canada, and UK. Broken line is 2016, hard line is 2007. So in 2007, we had this distribution. In 2016, we have narrowed the distribution and improved to the left. That means babies are getting better. In Australia, they have narrowed the distribution, but the mean has gone on other side. In Israel, no change. In the UK, again, the outcomes have worsened amongst their unit. So it is not, these are the countries that may have used the similar technology, similar knowledge, similar evidence to involve, but without immersive engagement, it doesn't work. So in short, what really helps or works, it's a networking. This is the principle that we adopted from the day one when the units were coming. We said that you need to start talking to your hospital administrator. You need to have a room for improvement next to your CEO's office. Not literally, but this is how seriously we asked them to engage. And we invited these administrators to our meeting to see what other units are doing. Because what you need is multi-pronged approach: leaders, engagement, motivation, building the system capacity, applying evidence, enhance your information system. You need data, and then finally share results. You finish this cycle and then you're continuously improving, because you also need teamwork. At a local level, you need teamwork, appetite, organizational support, training, and multidisciplinary engagement. And those are the facilitators of quality improvement. And those are ones which, when you are embarking in Southeast Asia, you should be looking for or trying to build. Because without that, the thread is not complete and the culture doesn't come. The most important piece is now that there is a quality culture in each unit. When they have questions, they know who to call, who to engage, and who to get help from. We have asked them to just go to other unit and sit there for 2 days and watch what they are doing. You go to the unit with a low infection and watch how and what they are doing. And then you will come back and see what you can imply in your particular unit. However, there are barriers. And the most important barrier is if you have hierarchical organization, apathy, overload issue, lack of engagement, and if you don't build the culture in the unit. I think those are the ones that will definitely not. Because everybody is coming, and if you throw another quality improvement cycle, people will say, oh, another one. Why? And why until that culture doesn't change, it doesn't happen. So if you want to embark, emphasize that you are doing quality improvement and not quality assurance. You're not going to send people home. Avoid all those mystical language of lean and sigma and stuff. Keep it simple. We are doing quality improvement. Relate to what matters to clinicians. We ask them to sit down with all the people in the unit and say what needs to be improved. And in some unit, it was the door hinge, because the door was closing with a bang and the babies were startling at each time with increasing heart rate, reducing oxygen levels. Accommodate within their workload. Give them space. Provide relevant data to them and update them that this was our infection last month, this is this month, and we'll continue to update. Highlight some academic aspect, because a lot of things can come out of this. And finally, do not forget, make sure you notify them fiscal agenda, because this is what all of us are doing to reduce cost. And that, if you don't articulate, it will be a talk in the background. So suggestion, I mean, I'm not in a position to tell you anything, but just start small. Our experience is start small, get few local or regional networks or NICUs to talk to each other, compare each other. Plan for exercise as it's an exercise in learning and not for punitive purposes. In the initial days, nobody was telling who they are when we present the result. Now, when I put up the results, the site with the worst outcome will stand up and say, I am X and I need help. Who is Y? I want to talk to you and I want to come to you and I want to learn from you. And that's the only way to improve. And be prepared to humbled. You may think your outcomes are great, which is what we thought in Canada in 2007. And we were humbled by looking at the international. I know there are some efforts ongoing. I've been talking to Dr. Praveen from Chandigarh and Ashok from Delhi, and they have some networks that going, and we are working with asking them to helping them to develop those, as well as anything that they can contribute and make us learn. Because I know things happen in India, which when I tell here, they just say, oh, how is it possible that you have 1.2 kilo baby going home? And here, those baby will be in the unit for months. So there are local regional efforts ongoing, and there are more that I may not be aware. But suggestion would be to start small and build. Time taken from data to community in collaboration now should be small. It shouldn't take anybody else 20 years with this technological advances that we have. And in the end, I would like to acknowledge number of people, but particularly patients and families who have allowed us to be with us and help us to guide our in engagement. I mean, nowadays, our parents are on our steering committee and they are telling the next quality improvement project that we should be taking. Because for them, does not matter baby has BPD or not. For them, they want to see baby's face without any respiratory support. It doesn't matter at 36 week, it happens at 37 week. 1 week earlier would be better, is what we have been hearing from them. I've been giving the lectures, but these are the people in the background who deal with the data, work with the data, and produce the data. And Dr. Shuli, who initiated this program. You can see in the front as well. With that, I will leave you with a couple of quotes. Making improvement happens with unshakable belief that everyone has two jobs when they come to do their work and to improve it. And we say that third one is to share with the other neonatal community. Again, and finally, Confucius said, I hear it, I forget. I see it, I may remember. But if I do it, I will understand. And that's what we are emphasizing in our. Finally, Mother Teresa, what you can do, I can't do. And what I can do, you can't do. So let's work together to do great things together. Thank you.
Thank you so much, Professor Shah. In fact, overwhelming presentation, and given so lucidly and so simply, I think it has refreshed the quality improvement process beautifully into each one of the participants' minds. We have a glitterati of neonatologists from around the country, and I'm very happy and thankful to all my colleagues from the National Neonatology Forum as well as NQCN for joining here, and senior obstetric colleagues and nursing colleagues and students as well. So without further ado, I have a lot of questions, but I will put my questions in the last. I have the privilege of asking the questions which have been posed in the Q&A. So we have Dr. Ankur Sudar. So I request Ankur to please unmute yourself and ask your question which you have posed here. So Ankur, can you please go ahead? So just a moment, I will just unmute Ankur. Just a moment, sir.
Okay, no problem.
Yeah, so Ankur, can you please ask your question to Dr.
Yeah,
Shah?
thank you. Thank you, Dr. Vikram. So, Professor Shah, thank you for this wonderful presentation. So, I am a quality improvement advisor. I try to coax get people interested in quality improvement, including Dr. Datta many years ago. So, one of the challenges I face in medical colleges in India in particular is that the residents or the students, senior residents, junior residents, they're just so busy, in doing their academic work, their clinical work, that sometimes, whatever little I'm able to speak with them, it seems to me it doesn't make sense. It feels as if I am talking to, blank faces, and the moment I go away, they will forget it. They just don't understand what planet I am from and what I'm talking about. So any tips there, anything that could help there?
Yeah, I think what we have taken, starting to take in that regard is ingraining quality improvement in their curriculum, in the medical school, in the residency, and in the post-graduation. So one of the things that we have started is that during that tenure of either doing the residency, that they need to be engaged with one quality improvement project, and they may not be leading it or something, but they need to get engaged with whatever is going on and understand, and try to do field work, not only just the paperwork, but the field work as to how to implement. And once they do themselves, they will understand the challenges, and they will be the one who will be bringing forth the solutions to come back. So I think we need to go right at the root and have quality improvement ingrained in their curriculum and how to do it. It's not like, I'm not saying that, oh, this is easy, let's start tomorrow. It needs a little more work and talk with the university. We have managed to penetrate in 3 universities now, and most of the universities are liking the idea and trying to work out how do they do that. So all the residents now in, let's say, University of Alberta has to do this EPIC program as part of their curriculum. So they have a 4-hour workshop that they have to do. And then if they take on the project, then there will be a facility to support those projects. And they are, so believe it or not, many of the residents are liking it and taking it on, because they feel that this is not, I mean, compared to research, this is an easier thing to do. But
right.
But I agree with you. I agree with your frustration too.
Thank you so much. Thank you. But that's helpful. Yeah, maybe going into the heart of academics, that is the curricula which binds what you can do, is the direction we should take. Thank you.
Thank you so much, Ankur. So, Dr. Shah, next we have Amol Joshi. Amol is a QI lead of NQSN. He is working in the Government Medical College at Aurangabad as associate professor, and he's one of the initial pioneers of quality improvement there in Aurangabad and Maharashtra. It's contributed largely to the national quality of care network, which to which you are addressing this talk right now. So Amol, please go ahead and pose your question to Dr. Shah.
Thank you, sir. Thank you for this nice presentation, and so many things. Actually, it opened up new avenues. We were slightly fixed on to our few ideas of point of care quality improvement, but then there are so many aspects to it. I didn't know, and thank you, sir, for that. But one question which has been lingering on my mind is we have been working in quality improvement since last 4 years and so. But then our teams are when it comes to maintenance of records for quality improvement. So the data at times is data keeping is a challenge, so much so that we lose the focus of actually improving the quality, and the maintenance of the data goes into the negativity of QI. So how to get out of it, and some tips for maintaining data, how it is a Herculean task to get such a data recorded at national level with such a network. Over to you, sir.
Yeah, no, thank you. Thank you for that question. So I must say that the platform that we started working on quality improvement was the data. So the data was already starting to flow from different units into a system. What we needed to do was to tweak the data, modify the data, and as the neonatology advanced, we worked on our database to capture what we wanted to capture, and retired what we did not want to capture, or we captured but that was not meaningful and stuff. So with the electronic technology, I mean, if you are using electronic health record, that will be easier. But if not, there should be someone who is collecting. It is a backbone of quality improvement. I mean, if you have a garbage data coming in, it's not going to make anything look better, even if you implicate a lot of intervention or anything you do. So you need to work on some mechanism. I think the one of the suggestion or advice I will have is that do not make your database 700 variables. If you don't need, if you need to start, just do it with the 20, 50, 30 variables that people can collect easily and that you can audit easily, and you can do some quality improvement with that. Once people see the value within those 30 variables, they will go to 35. They won't be resistant to go to 39 or 40 or 50. So build slow and go up. There is another way of just giving and going down with the 700 and providing resources to everybody to collect, but that usually does not work well. After some time, people just give up. So we started with the small and then built our database. Even for intervention, we started with saying that you just have to do 1 in 2 interventions in a year. I don't care what intervention you do. Just tell me 2 interventions you did, and that helped. I mean, since there are more neonatologists, I can tell you one of the intervention I did in my unit was at the bedside. I put a calendar. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And every day I asked the nurses that whenever you do skin breaking procedure on a baby, just mark 1 line up. So next day in the round, I see that date 7, there are 10 skin breaking intervention in that baby. And I said, why? Oh, because the resident came and asked for sodium, and half an hour later, somebody asked for gas, and 2 hours later, somebody asked for calcium, and then somebody asked for this. Why? So in the round, we decide that, okay, this baby will have this investigations today, and 10 went down to 2, and next day was 1. What it did, it reduced the infection. Now, did I collect this information? No, I just asked them to just look at that information next day in the round, and your infection rate will go down. And our infection went down significantly because we were not pricking the baby. So some things are to be collected and then reported, and some things are to be collected as a process indicator and not the outcome indicator. So you need to define those two and then see what balance you can. I hope I can answer your question, but.
Yes. Thank you so much for that, sir. Thank you.
Thank you.
Thank you so much, Amol, for that question. I'm very rightly said, Dr. Shah, that the value of data, in fact, we have been struggling at the national level to start sharing the data in India. It has met with a lot of bottlenecks. You're very right that dashboard data indicators, maybe in the FBNC program, that's facility-based newborn care program, we just had initially 10 data points which we were collecting across the units. It has now since grown with the SNCU online system coming up with the help of UNICEF, but definitely keeping it simple. And another very important point, sir, is like you just said, anonymized data. With each of the team knowing and they deciding to discuss and talk amongst each other, breaking the anonymity. I think that would be a great learning for the neonatal colleagues, and I'm sure it doesn't require a lot of initial investment. So any comments on the initial investment which you feel like 40, 50 units in a regional network sharing data? What sort of investment do you foresee in this?
So the initial investment I foresee is building a small database. In India being capital of information technology, I don't think it can take a lot of effort from a information technology specialist to create you an Access database or Excel database that can be deployed. People can collect and keep the data over there. So this is how we do it. We send this Excel data sets. So people collect. They have a copy retained at a local site for their own use and stuff. They only send the non-personal identifying information to the center. We analyze it as A, B, C, D, E, F, G, H, as you said. So nobody knows who is. Every year the A is different and every year B is different. So they cannot figure it out from over the year pattern as well. And still we are anonymous in that. But when we meet, everybody is telling, oh, I am J and I'm K. And it just lost that kind of thing. Unofficially, we all know who we are kind of thing. And that will happen because people will feel comfortable over time. So initial investment would be a small creation of small database, sending out that small database, and then training people or team from individual units for a 4 to 8 hour workshop. I'm happy to coordinate that. We can work it out the system. We do it in, we just finished in Australia. We are currently doing in Spain and training them. Initially, we basically kept it as a maintenance expense. So the expense for an institute was basically $100 for the entire institute to be trained for that, which is in a yeah, very low cost. And then we train. We basically train these epic 10 steps as to how to do it, and then help them to facilitate what happens kind of thing. We will be happy to train the trainers in the India. So then you don't have to come to us because really those trainers can continue to train the teams in India. So and applying the process and stuff like that. So that would be the minimum investment and somebody to be making sure that the data is correct.
Thank you so much, sir. I think that's a phenomenal offer. I think with our colleagues from both the networks, neonatal networks here and the quality of care network also around, we would be contacting you with this further and taking it forward to meaningful conclusion. It has been a dream in the neonatal fraternity, and I will come later to Professor Vani ma'am, and she would, I think, give her inputs on how NNF has been trying to, create a national neonatal perinatal database, and we launched it in 2003, 4, 5, and then it all stopped. And since then, multiple secretaries, including myself, we've been trying to get the efforts to, rekindle the database. So, Shashivani ma'am, any comments on what you just heard and how there could be a rekindling of a neonatal database on lines of what Dr. Shah has done in Canada, and we can restart that process in India, ma'am?
This subject has been a very crucial for us through NNF also. Even in 1990s, we prepared the first document about perinatal neonatal database. That time we even started with forming the definitions and collection of the data. Somehow I think, again we revived it. A second document has also come up, but we are lacking the leadership who can keep it continuously and involve all the centers. So that is one important thing. And we have to communicate with everybody about this. And as it has been suggested, we can pick up one by one topic, or at least there should be a center who can collect this data and keep the watch and continuously analyze and communicate and identify points for action. As he has said rightly, that we pick up minimum things rather than talking too many things. We pick up minimum things and act upon it, make some effort, and from that process, we can always build up. So I personally think we lack a good leadership who can communicate with everybody, collect the data, create a self for analysis also. We made the efforts till proper definitions, collecting the data, and but we failed at the level of analysis and then further communication. So I think we should fill up those gaps and we should take the help of these experts. And now that we have got more technologies, more instant approaches, how we can go step by step, we should be able to incorporate this. So I think it is a very, very highly needed thing for our country now, and some uniform things, because now we are preparing standard guidelines also. Now we have got definitions also. Now data collection system is also now robust, and now we have got many new technologies by which we can collect the data also, communicate with each other. So expenses are also much less than what it was in the yesteryears. So with all these advantages, I think we should have a leadership now who can coordinate all these things and take it further. So this is what we must strongly think about it.
Ma'am, I think we have the WHO regional advisor also here, and we have a lot of young leaders from the neonatal fraternity right through, and pretty senior leaders also sitting here. I'm sure your words will echo and will serve as a guiding light for the young neonatologists who are sitting here and upcoming leaders, ma'am. They are all leaders in their domains. And I'm sure they will look forward to networking all the neonatal ICUs in their area of influence. And with the support of Dr. Shah, I think we are getting into NNF. We can probably think about NNF and QCN getting together with Dr. Shah, form a collaborative and try and see how we could do it at the national level. So with this, I know this conversation very interesting. Dr. Shah, if you allow me 10 more minutes, sir, we would just take a few more questions. Thank you so much, sir. I understand you have a full working day ahead of you and it's early morning in Toronto. So we have a question from Dr. Harish Pemde. Harish Pemde is the director of the WHO Collaborating Center for Research in Adolescent Health at New Delhi. And Dr. Harish Pemde, please go ahead with your question. Yeah.
Thank you, Dr. Shah, for a very enriching presentation and touching very basic issues also. What I think is that people are not talking to each other. When I say people, the units are not talking to each other and not actually learning from the good work being done by one unit versus another unit. And if I take my own example from my hospital, what good work Department of Neonatology is doing is not so good work we are doing in Department of Pediatrics as far as neonatal care is concerned. But are we doing enough? Are we talking enough? Probably not. So what I feel that people still have this fear of losing out the reputation. What would people say if I reveal the data, say for hypothermia, for rate of infection, and for a host lost many things? How to tackle this fear in people? Because this very fear is stopping us to work on this quality improvement in various units in various places.
Yeah, no, and that is not to be ignored, and that is not. I mean, that is a true fear, and for that purposes, at this stage, what we do is the coordinating center. There are 2 or 3 people who knows where this data is coming from, not more than that, and all the reporting is anonymous. So you report it as A, B, C, D, E, F, G, H. And until everybody says, I'm fine, put my name up, all of you, which will happen in 20 years time, I can tell you, you just remain anonymous. We tried to do it even in Canada. I sent all the CEOs saying that, look, this is a public health system. We are doing public service with the public money. Let's put our name out in front of our report. because you can get our report out and you can see our reports annually being published on website where one can go and see. And half of them agreed and half of them did not reply. And because half did not reply, I couldn't do it, but I'm pushing them. And I said, why and what? Because there are other areas where hospitals are being compared on a national scale to see what is your infection rate and things like that. So why not this? So it will happen, but that fear should not be ignored. I would say that initially start with anonymized data. And once you see that 2 or 3 meetings later or 2 or 3 years later, annual meetings, people will come out and say, look, I am Y and I'm struggling. Can you tell us what to do? It takes time, but it will happen. But you just have to be patient and initially honor the fear.
Thank you. Thank you.
Thank you so much, Dr. Shah. I think that's Harish has very rightly said that when we started doing hypothermia work in 2015, sir, the hypothermia rate at Lady Harding was 83% in one unit, arrival hypothermia. And the first thing, I think most of the people here know this story so many times, you've told it. And when I was about to, put it up in one of the small meetings, my then head of the department told me, you're going to, declare you had 83% hypothermia. It's going to create a lot of problems. All my colleague heads of departments of Delhi are there. What they will feel, what we are doing. I said, sir, we will fix it. And we first have to acknowledge it. And that rest all is history, sir. So there was a great fear. And we also had a fear that it could get reported in press or it could go somewhere.
Yeah.
And, we've been sitting on this data for quite some time. So, sir, that Harish is very right. So, sir, very quickly, we will come to Dr. Rajesh Mata. He is the man behind the show, the regional advisor for WHO CRO, running the entire pediatrics, neonatology, adolescent work in the CRO region, 11 member nations, and the driving force behind this communities of practice. So, what do you, Dr. Mehta, sir? Please go ahead, sir.
Yeah, thank you. It was a pleasure to hear Dr. Shah today, and it reassures that we are following similar trajectory. Professor Shah says that he has been in touch with Ashok Derari. So with Ashok, when I joined in 2015, we had a regional framework on quality improvement. And then we invented or simplified the EPIC, IHI, and other models into a particular model called point of care quality improvement. I am sure Ashok has mentioned this to you. And so Ashok's network has helped us. Now Ankur's network, Vikram's network is doing great work in taking it forward. So my observation also is that there are two things which we are not able to ensure until now. One is motivation at individual level. We are able to excite people with the simplified approach of quality improvement without additional resources and trying to achieve success quickly. Excitement is there, but the people who will continue to do another project followed by another is minuscule. So we need a lot of post-training, contact and mentoring. So that motivation has to be further promoted. The second problem has been of sustaining the network. So Dr. Shashivani is right. We actually supported the first network in this region. 7 hospitals only, 2 in India, 1 in Sri Lanka, 1 in Myanmar, and 1 in Nepal. Until we paid money, it worked for 2 years. We stopped money, it stopped. Then ICMR took over for another few years. They supported, they gave money, it worked. After that, it again stopped. Now I have a network of 115 hospitals in the countries of this region, where I am getting online data on birth defects at the time of birth. When I asked them about, I also started getting data on stillbirths and the description of why the underlying causes of stillbirth or something. So details of stillbirth also come in. But the neonatal data form which is there, and we expect that neonatal data will come, only 4 out of 115 hospitals are able to give us the online data on newborn. So what I want to learn subsequently from you is, so what have been the slip roads and then highways to continue to sustain this. So I am looking it as with an optimism that we started in 2016-17 about this point of care quality improvement. And we published a documentary last year where we found the 9 countries in this region, and about 6 countries in Africa are using this. China has used this, Uzbekistan has used this, but until we keep on supporting them as you do in your network, so we look forward to that optimism that we learn from you, that how do we sustain this network. Vikram is doing a wonderful job, but how do we sustain this? And so Ashok has ignited, then it has gone to several countries, so we have worked together. So it was such a pleasure to listen to you that we are on probably correct path, but we still need to learn from you how to make it better and how to sustain this over next decade to reach where you are. Thank you.
Yeah. So two-part answer. One is to sustain it as a national or international level in terms of the unit engagement. We had the similar problem. So 97, 98, 2 years, we paid money for people to collect the data. 16 units collected, and by 2001, it went down to 5 because other 11 fell off, money was not there, and blah, blah, blah. And then we pivoted to quality improvement, saying that you send us the data, we will send you the report on a 3-monthly, 6-monthly, depending upon the volume, data back, so that you can see that your infection is going up, going down, this is happening, and target your intervention accordingly. The second thing that helped was accreditation, because the hospitals here needed to be accredited. And when they go for accreditation board, they would ask that, okay, well, yes, you say you are good, but how good you are? Compared to who? Kind of thing. So for that, they had to go somewhere. So then they started to come back. So slowly, it increased from 5 back to 31. And now it is hard for hospital to not contribute. Because if they don't, then the next year they will stop getting any report, and then they will be in trouble when they go to their administrator or anything, any kind of support to see that, okay, well, I need to reduce infection and stuff. So what we found was it takes time, and it takes the individual unit to realize that they need to do this before otherwise they will fall off and they will stay where they are or worsen, and people will keep on improving, kind of thing. The other thing we learned is that in this process, even the smallest hospital were the ones who were more keen than the large hospital, because they have no other avenue to be compared to. I mean, if you have a small hospital and if you don't participate in such a national activity, you will be lost, because nobody will come, nobody will bother, nobody will talk to you. So they were the one, they said, no, we don't want to stop. We want to tell us what we need to do to be continuing to be part of you, or part of the national network. So that's one part of kind of how to motivate. The second, for the unit people to motivate and engage, what we did was we took out the responsibility from unit directors and the bosses and told them that you need to give this individual project to individual team who will be dealing with it. I mean, baby is hypothermic. Probably doctors have nothing to do with it mostly. Before they come to the baby, doctors attend the baby is hypothermic. So there is some system problem. There is some nursing problem. There's some parental problem. So we said they should be the leader of that particular project and not you. You just be helping them and facilitate that to happen. So by giving those responsibility, we created champions in the unit. So for the central line infection, we had nursing champions. Because I mean, as a doctor, I never touched the central line myself. I put it and I'm gone, kind of thing. They are the one who are basically maintaining and taking care of those lines. So they were the champions dealing with it. They need a physician just to be a spearheader, but not the one who does the work. And that motivated the unit, because that nurse will go and say, no, we need to do this. This is our unit. And the third thing we did was a kind of a chart in the unit. We asked them that whatever you're working it, just put it out in front, right at the main nursing center. Okay. So everybody can see it, not only nurses and doctors, but the patients can see it, parents can see it. And then it became like a last, we have a board in my unit, last catheter related infection, how many days before? So it's 55, 56, 57, and the next day they come at 0. Oh, what happened? What did we do? Which baby? How did it happen? What was missing? And that becomes kind of a talk of the unit, that we had a infection in the unit.
So this is work culture. So how many years? So therefore, I would look forward to engagement with you to understand where are the tipping points, how soon, and what are the inflection points which we should recognize to give it a momentum. So allow me to then subsequently engage with you, Vikram. You
Absolutely.
maybe Ashok, we can join together and try to replicate what you did. So I don't think we will do epic courses now here, because the network is going on with similar. As you said, all of them are as good. But the process of taking it forward and reaching where Professor Shashivani wants us to reach, so we must continue this engagement. So
Absolutely.
such a pleasure. Thank you so much.
Thank you so much, Dr. Mehta, for those inputs. Dr. Vani, I'm just coming to you, ma'am. Just bear with me for a couple of minutes. We have 2-3 quick questions, Dr. Shah, if you allow me. From Ram Kumar, we have few of the questions were very interesting, but most of them you've answered. But one question I find very, intriguing, and that requires an answer from you. He says, by which time frame or year did the NICU units become comfortable with parents being an active part of the baby's management? This is important aspect for the Indian situation. So family-centered care, sir, like in your journey, like from EPIC 1 to EPIC 4, at what stage did you, because we are getting the parents in, and Sashivani ma'am is here. I would say she's the one who's like expanded KMC right across and started all with KMC and then moved to family-centered care. So what's your experience, sir?
Yeah, so that started at around 8 years ago when we were looking at this international. We went to Estonia. And in Estonia, what we observed was there was with every baby, there was a mother's bed in the unit. So each baby had a mother sitting there right from the birth. Mother was transferred there and mother will stay there. And that mother will stay there with the baby for 2 months, 3 months, 4 months, because they have 2 years of maternity leave. And mother's job is to take care of that baby for 2 years, nothing else. And that's where we started learning that, okay, well, this is the most important part kind of thing. And we did a cluster randomized control trial of family integrated care in Canada, because again, we went through the same cycle and now it is kind of an engagement. For last 7 years, the parents are on the steering committee of our network and they are the one guiding it. At each unit, there is a parent council or a parent advisory committee, which will basically look at it, what is happening, and advises the unit what next and how to introduce these concepts or quality improvement projects within the unit. So it has been 7 years that they are actively engaged. Now we are partners, basically. None of my grant goes in without a parent being a principal applicant in the grant.
That's great to know that, sir. So we have a short question from Ms. Jeena Pradeep. Jeena is a nurse leader and she has been decorated by the President of India as one of the best nurses of the country by the Florence Nightingale Award. And she's one of the founding members of NQCN and currently the treasurer as well in the organization. So Jeena, please go ahead with your question.
Sir, thank you so much, sir. Sir, I would like to know what are the most favorable factors to undertake any QI project at any healthcare facility for that matter. What do you think these minimum 5 favorable factors should be there before starting any QI project? Because most of the time we feel that if we start with any QI project, that will affect the other quality of care because we have such infrastructure and this thing. So I would like to know what are if you recommend these minimum 5 most favorable factors should be there to start any QI project for any
facility. Thank you very much and congratulations for your award. And I would say I would go back to the slide to tell you the most important 5 factors. So first of all, teamwork. You need to have a good team. And that team means everybody taking care of the patients. Second is appetite. The unit wants to improve because whatever you throw to them, and if there is no appetite of change management or change implication happening. Third, you need organizational support. So you need central support. You need your administrators behind you in supporting you. They don't have to be there and doing everything, but at least they don't want to block you, and occasionally provide you with infrastructure resources that you need. Then you need training. Quality improvement is not that, oh, I came here and I'm going to do 10 times hand washing instead of 5 times I used to do or something. You need training as to how to introduce a project, implement a project, audit a project, and then look at the results kind of thing. And that requires a multidiscipline. So these are the 5 variables that you are asking me. I would say should be there as a main ingredient for any quality improvement project, and they will facilitate what happens in a unit.
Thank you, sir.
So, Dina, I'm sure you got the answer. And sir, most important point is that whether there is an appetite. So the other day I was speaking to Dr. Nachiket Moore, who was heading the Bill and the Melinda Gates Foundation in India a few years back. And he mentioned to us that we are trying to push quality improvement into the Indian healthcare system. But he asked me, Vikram, is there an appetite? Is somebody asking you that, yes, we want quality improvement, come and give it? Dr. Mehta is funding it from WHO, UNICEF, Government of India is funding it. We as a part of network, volunteers, obstetricians, neonatologists are going across the country, just trying to, create that appetite for the last 6 years now. But is that appetite still there in pandemic times, sir? We have noticed that that appetite has significantly decreased in a situation where it should have increased for the optimal utilization of the resources. And sir, that is something which got all of us thinking. How do we create the appetite in the system? Sir, my question, which is the penultimate one to you before I conclude with Dr. Vani, sorry ma'am to keep you waiting for so long, is that how do, in your experience, we create the appetite into the system? So point of care teams, okay, they are in my area of, control or area of influence. I can do it as a unit head or as a head of the department or as a nurse leader. But how do I scale it up across networks, across units, into various national health missions? How do I get the appetite?
Yeah, I think appetite is two ways. So at a unit level, what we have suggested in the training program and stuff is celebrate small successes. So even if you have a 2% reduction in infection, celebrate with your colleagues, share with your colleagues, because what happens is that most of the times we throw interventions to the unit, they do the intervention, but they don't know what happened after that. And unless they see the results and they see that, okay, well, whatever they did, something happened kind of thing. And then they will be more interested that, okay, now the new thing, let's see what happens with it. So that kind of interest and enthusiasm keeps going if you start celebrating some successes, as well as inform them that, look, we did this and it didn't work. And we are rethinking as to how can we make it either work or better, or that we just need to look at something else. So from a local point of view is just encourage them and show them results and show and work with them kind of thing as to what matters to them, and then go for that. At a national or other level is, again, you just, we basically continue to send 3 monthly report. Now we are sending 6 monthly. And the last 2 years, we have been basically online. So they can just go and themselves look at their results compared to the other units in the country kind of thing. So I don't have to send the report, but I constantly still, in order for them to go and look at the report, I every 3 monthly send that, by the way, your report is ready if you want to go and look at it. And that reminds them, because otherwise, if you just put it line, again, they will forget. So constant reinforcement and some celebrations would be my suggestion.
Thank you so much, sir. With that, I come to the last part of today's session. We hate to end it here, sir, with such an engrossing discussion and such enlightening. We would like to have you once more in the session to continue these discussions at a later date of your convenience. Of course, Shashivani madam, over to you, and sorry for keeping you waiting for such a long time, ma'am. Please.
No, it's
I
okay,
completely
just
agree with you to come and again talk kind of thing, but stop saying me, sir, Prakesh. Then only I'll
Thank
come.
you so much. Okay, Sashi ma'am.
It was an excellent learning session for me. I just wanted to ask only one question. For quite few years, I have been toying with the idea of developing a QI program for improving KMC in our country. So is it possible to develop a TOT only with a focus of KMC and quality improvement rather than making it too big and too thin? But if I have the KMC program, because we have now got some experience in that, so naturally this is the point which we have been talking right from our first conference, that improving the quality and the coverage, only then we will achieve the ultimate objective of reducing morbidity and mortality. Otherwise, just telling skin to skin contact and this is going to do this and that, it's not going to lead anywhere. On the contrary, if we don't see the results, it may boomerang and people may lose faith in that. So that anxiety is there. So I am really keen to develop one TOT only with the focus of KMC. So is it possible, whether you all will help us? I have been trying to knock so many doors, but I am not still getting, but today at least I have got some hope. So with that idea, I'm asking, and we want to introduce this in our network also.
Yeah, no, absolutely. It is always possible. I think what we need to train them is to how to do it. And then they need to look at that fishbone diagram individually.
Right.
What is blocking in that particular unit? Because every unit might have a blocking point, or the work or the idea that which can help them, like prioritizing, may be different for different unit. And that's what we have avoided. We haven't said everybody that now you have to do this or you have to do this. We just say you work out your process, but we can say that this is what we are. Our goal is to improve the kangaroo maternal care. And you work out the fishbone into your particular setting as to what are the few people, process, ideas that are blocking it. And then what are the prioritizing of the intervention that you want to do? 1, 2, 3. And that may be different. Some may have first separate than other ones and stuff, and then help them how to implement that. And that probably will lead to better. However, I must say that I had a meeting 4 weeks ago with Rajiv Bal, and he, after the publication of the New England Journal paper, I was asking him how I can do this in the developing countries or in INEO, the kangaroo mother care, because the way it was outlined in the trial is not happening in here. I can guarantee and I can tell you. And we want to do that here as well. So we would be learning from you too.
So Rajiv Bahal is organizing implementation research now on that KMC. So Chilani is looking for a replication model from Safdarjung Hospital. It's a radical change in government circles to actually allow mothers to stay inside. So, but with this collaborative, application of minds, I think Professor Shashivani idea can further be amplified. It is not TOT on KMC, but enabling them to identify their own problems, their own deficiencies in the process, and improve. So then we can probably come together, and there is great demand on you. So maybe in next slide, you will also mention Vikram along with Shah and Praveen. So this is how our network will get recognized. So thank you so much. And we look forward to meeting you again, even in a small group. Thank you.
Absolutely.
Thank you very much. And we'll continue this later. Okay.
Yeah. So we very quickly, the last part of the comments from our new incoming Secretary of NQC and Praveen Venkatgiri. Praveen, can we have a question, please?
Thank you. My question.
Yeah.
Professor Shah, thanks a lot for the session. And, we all kind of had queries about how to implement within our units as well as a network. And through your elaborate kind of discussions, you have given us some insights. but we all kind of would like a continuous engagement with you, so that that kind of a learning that over the years or decades that you had would definitely help us to make it faster. And that's what our aim is going to be. We will start small, but we would want to reach the place where you are at currently. Thanks a lot for that. Thank you.
Thank you.
So we have Professor Sushil. Sushil, your comments? Any concluding comments here?
I think it has been a wonderful experience hearing your work through the years and decades, and that has inspired all of us to continue this work of quality improvement and collaborating. There were a lot of questions, many were answered, but yes, better next time. We'll be looking forward to be interacting again with you and learning from your experience. We are trying to pick up more units in our collaborative network, and whatever you have shared with us has helped us definitely, and we will try to implement them in our own way. Thank you. Thanks a lot. And I wish to thank all the your participants today for making up with this wonderful talk, wonderful experience. I'm pretty confident that many of the neonatologists and quality improvement enthusiasts would be going inspired today from this talk, and taking that it takes time. We are on the right track. Let's stick to it. Let's find champions. Let's celebrate success, and let's build up our network. With that, thank you all, and I thank Dr. Vikram for getting us to know such a wonderful person and such a wonderful work. And for any recording of these presentations, it will be put up on our website. So the participants, and I will request your teams. In fact, I'm going back to my neonatal unit and requesting all my team members to have a look at this talk and get a good perspective about how things have to be done. So thank you all. Have a good day and stay safe. Yeah. Thank you. Bye.
Thank you very much. Thank you for having
Sushil,
me.
And thank you so much, Professor Shah and Shashivani Madam, all the esteemed panelists and the most esteemed participants for making this a great success, including Dr. Rajesh Mata, sir. And the popularity of this session, it extended nearly 40 minutes beyond its time. Still, there are some questions that are still unanswered. So, Professor Shah, I'm sure when the travel lines open up, we'll probably love to be visiting your unit one of these times and trying to learn firsthand how we can, identify these setups and bring them across to LMIC economies and Southeast Asia network. And just as a parting line, I would just like to mention that NQCN till date has more than 231 units which are networked across the country. And we have 4 networked nations in our communities of practice network platform: Maldives, Bhutan, Bangladesh, and India. And we're extending it to Thailand and Sri Lanka very shortly. And at the same time, we have impacted nearly 0.6 million deliveries till date in a short journey of 3 years of the network, and nearly 1 million lives which have been impacted. And recently, NQCN has been interested with bringing out the BMJ South Asia Open Quality Edition. The first edition is already out. I will just be mailing the full content to you. It's up on the BMJ Open Quality. The second edition is due shortly, and it is generating a lot of robust data from the subcontinent. So we will be looking forward to a lot of support and guidance from you, sir, because you are ahead in this journey and you are one of us. So we would definitely like to take the guidance from you in this fascinating journey. And thank you so much, sir. The session has entirely been very enriching, like we expected. And we look forward to welcoming you again at a subsequent session. Till then, everybody, we look forward to visiting, to having all of you in the Patient Safety Day event on 17th. And we will be sending the flyers. We've already sent the flyers. We look forward to, there are lots of activities which are happening. Please visit the website for further details. I'm not taking Professor Shah's time on a busy morning to announce all the activities now. And thank you so much. Have a great day ahead, sir. And thank you, everyone. Good night.
Thank you for having me. Thank you.
Good night.
Looking forward. Good night.